Aloha and welcome to part 2 of ECG, this week's week 2 lecture. So continuing on, so the QRS complex, it's depolarization of the ventricles, and it should be less than 0.10 seconds or 2.5 boxes, whichever way you want to look at it. If the QRS is widened, that is suggestive of a blockage in the conduction system, which is either left bundle branch block and right bundle branch block. And I'll teach you how to identify that on an ECG because you'll need to do it. That lengthening or widening, so it's either lengthening of the time it takes to depolarize through the ventricles, or if you want to think of it, widening of the QRS. Ischemia can cause that, necrosis of the conductive tissue, and electrolyte abnormality, or something that we realistically won't see, but hypothermia as well. So this is the wide QRS. This is bundle branch block. So you can see right bundle branch block, how you get RSR prime, and you can see it in V6. Easier to notice in V1. However, in left bundle branch block, in V6, you'll get what's called the rabbit ears, where you can see R, and then it goes down a bit, and then another bit to the R wave. And notice that it's widened. Pardon me. Okay, apologies. So anyhow, so you do need to be able to differentiate between right bundle branch block and left bundle branch block. So don't worry about it halfway through. So T wave. So the T wave represents repolarization of the ventricles. Primarily, if the T wave is elevated, and it normally is elevated quite a bit, it's indicative of hyperkalemia, or they've had myocardial infarction. If it's flat, then that also may indicate ischemia or a myocardial infarction, or could be any other issues. You just be able to really need to differentiate between, is it normal or is it abnormal? And we've had students in our OSCEs, and they get an ECG, and they know it's abnormal, but they can't remember what either the arrhythmias, etc. Look, you get half the points because you recognize that it was abnormal, and big deal that you didn't really know what it was, etc. So don't worry, but you need to be able to identify if something's normal or abnormal on an ECG. So this is hyperkalemia, and look at those T waves, how peaked they are. So you can look at that immediately and tell that there's an issue. So the QT interval, this is really important because long QT, so the QT is measured from the beginning of the Q wave till the end of the T wave, but you need to know long QT because of what's called sudden cardiac death. So for the QT interval, it's got to be relative to the heart rate. So that's why you see it listed as QTC, and the C means that it's corrected for heart rate. It's also gender specific. So for males, for example, if the QT interval is 450 milliseconds or 470 for female, it is indicative of what's called long QT syndrome. And no exercise, they have to be sent to their back to their GP and give them a copy of the ECG. Medications can lengthen it, or hypothyroidism or hypocalcemia, but you just need to make sure that the GP can quantify that it's not, they're going to send them to a cardiologist, by the way, that it's not long QT syndrome. So speaking of long QT, you can see prolonged. Don't worry about normal, borderline. You just need to know those values or recognize it on an ECG. So summary, so you need to know your P wave intervals, your PR, QRS, QTC for men, QTC for women. Now, what about ST segment changes? So really, you look at the ST segment, and remember I spoke about the isoelectric line. You need to see whether or not it's elevated or depressed, and then it's suggestive of either having an anterior or inferior myocardial infarction. So what types of pathology can we identify from ECGs? So you can identify arrhythmias. You can tell whether or not somebody is having or had myocardial ischemia or an infarct. Pericarditis, chamber hypertrophy, either if they've got left ventricular hypertrophy, atrial hypertrophy, etc. If there's any electrolyte disturbances or any drug toxicities. We don't see dig toxicity too much these days because very, very few patients are on digoxin. It's used in heart failure. You will, as AEPs, see quite a number of patients that have heart failure, but it's pretty rare this day that you'll see a patient on digoxin. Now, this is the cardiac cycle, what's called electromechanical. Just to sum it all up for you, where you've got the ECG, so just down here in blue, and then you've basically got the changes where aortic valve opens, closed, etc. And you can see the pressures that occur. So just familiarize yourself with that. Now, what about the conduction system? So we spoke about this before. So the normal sinus rhythm, it originates, that's the right atrium, in the SA node. Then it goes over to the left atrium, down to the AV junction, down the left and right bundle branches through the Purkinje system to the ventricles. And you can see the conduction velocity is altered. If there's sympathetic stimulation, it increases it. If there's vagal stimulation, it decreases it. If there's either been ischemia or hypoxia to that part of the heart, it decreases it, and depending on how long it's ischemic for, etc., that tissue may die, and medications may increase it or decrease it. So the conduction system. So you have the internodal pathways where it goes from the SA node over to the in the right atrium to the left atrium. You can see the conduction through the AV node, through the bundle of His, through the bundle branches, through the ventricular muscles, and through the Purkinje fibers. Now, normal sinus rhythm. That's where it starts in the SA node, then goes to the AV node, down the internodal pathways, through the bundle of His, the left and right bundle branches, through the Purkinje system, or the Purkinje fibers. Now, continuing on, so the SA node, as I mentioned, it's in the upper wall of the right atrium. It's responsible for pacing of the heart in normal sinus rhythm. It has automaticity that it will beat at roughly 60 to 100 beats per minute normally. Now, the electrical impulse is conducted from the SA node through the interatrial pathways to get over to the left atria and then down also to the AV node. The interatrial pathway, it's also called Bachmann's bundle because there can be a problem there. It travels through the right atrium, through the anterior, middle, and posterior internodal pathways. And those electrical pathways spread the impulse across the atria down to the AV node. These are the interatrial pathways. So you can see during normal sinus rhythm, it's the preferential path to get from the right atrium down to the left atrium and through the right atrium itself, getting down from the SA node to the AV node. So you can see it here a little bit enlarged. You can see spread through the right atrium over to the left atrium. And remember, blocks can occur at any one of these sites. Now, the AV node, it's in the upper right atrium, just behind the tricuspid valve. It lacks automaticity, meaning that it can't initiate an electrical impulse. But the junctional tissue can initiate a rhythm, and that's called a junctional escape beat. And it's slower at 40 to 60 beats per minute. The AV node conducts the electrical impulse through the atria to the ventricles, but it delays it for about 0.04 seconds. So speak with your tutor in terms of why is there a delay at the AV node? And I'll give you a hint, it's advantageous. So this is the bundle of His. So the electrical impulse travels from the AV node and it goes down the bundle of His where it splits into the right and left bundle branches. And that's how we get it. You can see on the right, that's how we get it through the right ventricle, the left ventricle, and the Purkinje fibers. Now the bundle branch block. So the bundle branch tissue may initiate an electrical impulse if the SA node and the atrial tissue fail. Now the inherent rate of the bundle branch is about 40 to 60 beats per minute. So this is right and left bundle branches. So I've covered this before. That's right bundle branch block where you've got RR prime, left bundle branch in V6 where it's called rabbit ears. Now, what about the Purkinje fibers that are in the ventricles? So impulse travels from the left and right bundle branch through these Purkinje fibers to the ventricular cells. Now, the ventricular tissue may initiate an electrical impulse either if the SA node fails, the atrial tissue fails, or the junctional tissue fails. And the inherent rate of the ventricles is much slower at about 20 to 40 beats per minute. Now, I spoke about the isoelectric line. So you can see on this top one, you can see how that's a straight line going across. And again, we need that isoelectric line for relevance to the ST segment, because that's where you determine if there's elevation or depression of the ST segment, and it may indicate that they've had an infarction, they've got ischemia, pericarditis, or if they've got electrolyte normality. Now, you'll notice how long the ST segment is if you look through here. So the question is, where do you measure it to determine ST segment elevation or depression? Well, it's called the J point. And the J point is 80 milliseconds after the end of the QRS complex. So whatever right at the J point is, if it's above the line, it's ST segment elevation. If it's below the line, it's ST segment depression. And I'll show you some examples of those. So there's the J point. You can see the isoelectric line. So there's no ST segment changes. Notice here, here's the isoelectric line. But notice that the J point is 2 millimeters above. So that would be called 2 millimeters upsloping ST segment depression. You can see it here. That's about 1.5 millimeters, again, upsloping ST segment elevation. Notice here that the J point is actually below the isoelectric line, and it's here probably 2 millimeters ST segment depression, and you can see it's upsloping. Don't worry about a J wave. Really, you never see one. Now, again, just as review, types of ST segment depression. This is downsloping, this is upsloping, and that's horizontal. Now, the U wave. The U wave isn't really seen all that often, but it can be seen if there's an electrolyte abnormality or certain medications. So this is long QT interval. So long QT syndrome, we spoke about that earlier. It's one of the leading causes of death in athletes. It predisposes the individual that has long QT to something that's called torsades de pointes, which is basically a type of ventricular tachycardia. Ventricular tachycardia is a pre-lethal arrhythmia. So they go from VTach to VFib, and then unfortunately, it can be fatal after that. So I know, in Australia, you probably don't know it, but Hank Gathers, who was a famous basketball player, in 1990, while he was playing, he stopped taking his medications, and he ended up dying from the long QT syndrome. Sorry, I'll just go back. It's hugely important that you can identify long QT on an ECG. So this is a study by Ackerman. This comes from the 36th Bethesda Conference recommendations. And it recommends that if an athlete has long QT syndrome, they shouldn't participate in most sports. So they screened 157 athletes that had long QT. 17% of the athletes, when they were told they had long QT, disqualified themselves and stopped competing. Of the remaining 130, one had long QT with adverse events. He had to be defibrillated twice and survived. I don't have anything after from this paper from the Journal of the American Medical Association, but clearly the athlete shouldn't be doing any sporting activity, having been cardio converted twice and survived. Now, this is the chest leads. We'll cover these in the lab to show you, but V1, V2 go in the fourth intercostal spot. V4, you just go to where your left arm, right arm is. So you go mid-clavicular down to V4. V6 goes mid-axillary, and then V5 goes equidistant between V4 and V6, and V3 goes equidistant horizontally and vertically between V2 to V4. Now, these are the chest leads. You can go through yourself, where you can see fourth intercostal space, V1 and V2, all the way down to V6. And again, we will cover this in lab. So what about those chest leads? So V1 and V2 look at the right ventricle. V3 and 4 look at the septum and the lateral left ventricle. V5 and V6, which are all the way around, looks at the anterior, which is towards the backside, and the lateral left ventricle. This just shows you looking at what we were just speaking about. So there it is in the heart, and you can see V6 all the way on the lateral side. So ECG hypertrophy. So technically the best way to determine left ventricular hypertrophy is through what's called echo Doppler. But you can do it off of an ECG. And what you do is you look at in V1 or V2, they'll have very deep S waves, and V5 or V6, they'll have very high R waves. So the diagnostic criteria for ECG left ventricular hypertrophy is you take the S wave in V1, you take the R wave in V5, add it together. If it's greater than 35 millimeters, it's indicative of ECG left ventricular hypertrophy. And remember, that can either be in an athlete that's strength trained, power trained, etc., or somebody that's got, or it could also be in an endurance athlete, but it could also be in somebody that's got long-standing hypertension. Now, axis deviation. You need to be able to determine axis deviation, and I'll show you a couple ways, but the simplest way is the quadrant approach. So you need to be able to do it because it is suggestive of disease. So they may have pulmonary hypertension if they've got right axis deviation, or pulmonary embolus, or left ventricular hypertrophy. You can see in the example, look how thick that left ventricular posterior wall. That's the interventricular septum. That's the right posterior wall. And you can see, because of that increased mass, the vector of the heart, which is magnitude and direction, is going this direction. So if the axis falls between -30 to +90, and you can see that here, that's called normal axis deviation. If it goes from -30 to -90, it's left axis deviation. If it's +90 all the way to 180, it's right axis deviation. And if it's +180, basically back around to -90, it's called extreme right axis deviation, or no man's land. It shouldn't be up in there. So we're teaching you the quadrant approach. It's easy. You only need to look at leads 1 and AVF and determine if they're positive or negative. So in simple terms, if 1 is positive and AVF is positive, it's normal axis deviation. Yes, I know it's -30 to 180, etc., but all you have to do is just get it to the quadrant. If lead 1 is positive and AVF is negative, it's left axis deviation. So this is the table that you need to learn, and this generally sums it up for you. So left axis deviation. So it occurs when the electrical force moves to the left with hypertrophy, or when the time required for the electrical activity move over the left ventricular mass is long. So I mentioned hypertension can cause that aortic stenosis, regurgitation, or in athletes. So that's called pathological left axis deviation. There's also physiological left axis deviation, which is what you see in healthy athletes. So left axis deviation, again, you can see here, it can be attributed to hypertension, valvular disease, specifically aortic, or what's called WPW, Wolff-Parkinson-White. So look at this ECG. We can see 1 is positive, AVF is negative, lead 1 positive, negative, left axis deviation. Sorry, I'll go back to the question. Why would an aortic valve problem lead to left ventricular hypertrophy? And we'll talk about that in your labs. So right axis deviation, that means where the electrical forces are going to the right. So your lead 1 is going to be negative, and you can see that here. Your AVF is going to be positive. So we always think of lung-sided issues. So COPD, chronic obstructive pulmonary disease, emphysema, pulmonary emboli, could be vascular disease, could be a septal defect, or pulmonary hypertension. A septal defect, so you're aware, you've got the septum which goes between the right atrium and left atrium, right ventricle and left ventricle. A septal defect means there's a hole that allows blood flow between the left and right side. So what quadrant? So we go to 1 AVF, and we can see they're both positive. What quadrant here? We can see 1 is positive, AVF is negative. So we can see if 1 is positive, AVF is negative, it's left axis deviation. So it's very simple. So here we can see 1 AVF. So lead 1 is negative, lead AVF is positive. We've got right axis deviation. Now, I'm giving you this for your information. You won't see it on an exam, so don't panic over it. You can, off of an ECG, get the exact axis deviation. And this is what you use. You use leads 1 and 3, and all you do is in leads 1 and 3, you take the R wave with the Q wave, if there is one, and you sum those together. And you can see that we go across lead 1, and that's a plus 6.5. So you just draw an intersecting line. We do the same thing with lead 3. The R wave is plus 3, S is 0, so the sum is plus 3. And where they intersect, you now go from the center through that intersect and draw a line straight down. And you can see that roughly it's 48 degrees. So on this one, you can see that the lead 1 is plus 13.5, lead 3 is 9. The axis deviation drawn straight through is about 53 degrees. So questions, I know you'll have lots, so I'll stop now and I'll upload this to Blackboard for you. Mahalo.